Okay, everybody, Dr. Rafich here from Vet Triage. We are continuing through this June 15, 2015 edition of JAVMA, and we are talking about what is your neurologic diagnosis. So this is an 11-year-old neutered male Yorkshire Terrier with pain in the thoracolumbar region and a sudden onset ambulatory paraparesis. So the study comes out of University of Mississippi. So sudden onset makes no sense. We like to use medical words. So, usually when you talk about the timeline of events for a case in terms of symptomology, you're talking about paraacute, which happens very, very fast, usually within like a couple hours. Acute, which could be days or something like that, hours to days. And then chronic, which typically is 7 days or more. So sudden onset doesn't make any sense. It should be paraacute or acute onset. Ambulatory means the dog is walking. Paraparesis implies neurologic weakness of the hind limbs. So para is the hind limbs and paresis is weakness. The dog had bilateral hind limb ataxia, a chronic diabetes mellitus, bilateral cataracts removed via phacoemulsification surgery. The dog was on insulin. On physical examination, he also had a pendulous abdomen, cranial abdominal organomegaly, bilateral weak femoral pulses, and symmetric mild ventral abdominal alopecia. On neurologic examination, they found pelvic limb ataxia. They found weak postural reactions with hopping in both pelvic limbs, as well as proprioceptive deficits in both pelvic limbs. Spinal reflexes were exaggerated in the pelvic limbs, and flexion was diminished in the pelvic limbs. And by the way, when you look at this chart here, you see here some NE, which is not evaluated, which I just don't understand. I don't understand why you'd publish a paper like this with an incomplete neurologic examination, considering this is a what is your neurologic diagnosis paper, and why wouldn't you just examine all these things? It's a Yorkie. It's not that hard to do. It's a 6-pound dog, or rather a 6-kilogram dog, 13 pounds. So this type of incompleteness for a case study is insane to me. It's just bad publications. Anyway, the problem was ambulatory paraparesis and ataxia with bilaterally decreased postural reactions, withdrawal deficits, and sudden onset thoracolumbar hyperesthesia from T13L1 region of the vertebral column. They ruling out focal or diffuse spinal cord lesion within the T3L3 region of the vertebral column, L6 to S2 spinal cord segment or sciatic nerve. In addition, they found weak femoral pulses, which indicated some sort of either cardiovascular issue like low blood pressure or thromboembolic vascular disease. Likely location of the lesion with T3L3 spinal cord segments. Differential diagnoses include intervertebral disc disease with disc extrusion or protrusion, neoplasia or infectious or inflammatory myelitis, myelitis, inflammation of the spinal cord. Fibrocartilaginous embolic myelopathy and discospinalitis were considered less likely, and the weak femoral pulses and the weak pelvic limb withdrawal responses indicated maybe a vascular occlusion cranial to the femoral arteries with underlying cardiovascular disease or hypotension. So they ran some blood work. The complete blood count had high neutrophil count and high proteins. Most hospitals don't have proteins on their CBC, on their complete blood count, so I'm not sure if that's an error there or if the Mississippi State University has proteins on their CBC. But then they ran a biochemistry panel which showed hyperglycemia, high BUN, which is blood urea nitrogen, total proteins were elevated, globulins were elevated, high cholesterol, high alanine aminotransferase and alkaline phosphatase, high creatinine kinase, and then protein in the urine. So let's go over some of these lab results. So high white blood cell, high neutrophil count in the complete blood count can be anything from inflammation to infection to neoplasia. The high protein content could be due to either dehydration or hypovolemia, or it could be due to hyperglobulinemia if the body is fighting inflammation or especially with infection, which this dog does have high globulins. The elevated blood urea nitrogen with a normal creatinine implies typically an ingestion of blood causing a high urea nitrogenous concentration, so typically with a stomach ulcer, or things like the dog is on a carnivorous diet, high protein diet, could also do that as well. It could also be early renal insufficiency, but the doesn't really fit that here because the urine concentration was normal and the dog doesn't have any history, at least based on this, of polyuria, polydipsia. High cholesterol, high liver enzymes, those indicate endocrinopathy. That's a pretty good combination of an endocrine problem, which could be from the diabetes mellitus or some other new endocrinopathy. And then the creatinine kinase being high, which is not the same thing as creatine, or creatinine rather. The creatine kinase is usually due to muscle damage, muscle trauma. And then protein in the urine indicates a renal leakage, which could be from renal insufficiency, like we said, or it could be from endocrinopathy. So they collected, I think, radiographs. They don't say here, they just say here, results of thoracoabdominal imaging were consistent with hepatomegaly. So I think radiographs, again, I don't know why this is such a poor publication. Echocardiography found mitral and tricuspid valve regurgitation from endocardiosis. They performed an MRI, and here's the MRI here. So you can't really see it too well, but the dog's head would be here, tail would be here. This is a sagittal view. And this brightness here is the aorta. It's blood in the aorta. And then you can see here there's a big clot in the descending aorta in the abdominal cavity. So that's the problem. So they found on the MRI mild to moderate areas of compression from T12 and 13 and L7 to S1 intervertebral disc spaces. They found a non-enhancing, so this is going to be non-enhancing, heterogeneous, sharply marginated luminal structure, iso or hyper-intense and T2 weighted images, hyper-intense on STIR images, hypo-intense on T1 weighted images in the abdominal portion of the descending aorta caudal to the renal arteries. Time of flight angiography of the abdominal aorta revealed abrupt termination of flow extending from the level of L4 vertebra into the left external iliac artery. Findings of the abdominal ultrasound with color flow Doppler agreed with the MRI, finding an echogenic thrombus in the distal portion of the aorta extending into the left external iliac artery. Markedly reduced blood flow was evident, as was bilateral adrenomegaly. So aortic thromboembolic disease with chronic intervertebral disc disease and subclinical endocardiosis, adrenomegaly, thromboembolic disease, and everything was pointing to hyperadrenocorticism, which is Cushing's disease. They ran an ACTH stimulation test and confirmed the diagnosis. They confirmed pituitary-dependent hyperadrenocorticism because of the lack of MRI and ultrasound findings that showed macroscopic adrenal gland tumors. So because both adrenal gland tumors were symmetrically enlarged, that typically tells you that the stimulation for excessive cortisol production from the adrenal glands is coming from a pituitary tumor, and that's what's causing the adrenal glands to be plump and releasing cortisol versus the primary disease of the adrenal glands. Also, around the area of the aorta was edema, fluid stasis, or proteinaceous fluid. Comments. In dogs, aortic thrombosis or thromboembolism is uncommon. Cats with aortic thrombosis and thromboembolism generally have cardiac disease with predispositions for left atrial blood turbulence, thrombosis formation, and subsequent embolization of the aortic bifurcation. It's also called a saddle thrombus in cats. In dogs with aortic thromboembolic disease, focal thrombosis of the distal portion of the aorta is seen as a result of underlying prothrombotic disease, like a protein-losing nephropathy or endocrinopathy or cardiac disease or paraneoplastic. Lab findings include a high serum creatine kinase and plasma D dimers. The treatments would include tissue plasminogen activator or streptokinase or warfarin sodium or heparin sodium or dalteparin sodium aspirin or clopidogrel bisulfate, or you can consider surgery with thrombectomy. The median disease-free period is 24 months, so about 2 years in one study. Aortic thromboembolic disease in this case was treated with warfarin. In that study of 24 months, they were treating the dogs with warfarin. In this report, the dog was treated with enoxaparin sodium, clopidogrel, and aspirin, as well as insulin, cage rest for the disc disease, and then trilostane for the Cushing's disease. hyperadrenocorticism in a hypercoagulable state with loss of antithrombin 3 was considered the likely pathogenesis of this condition. And they kept following the thrombus with ultrasound and finding that it was getting smaller and smaller in size with more and more blood flow around the thrombus. So a very cool study. Again, I'm going to comment on the quality of the publication. It's weird to have a neurologic diagnosis when you don't have a neurologic diagnosis. I understand the dog does have disc disease, but it wasn't the primary cause of what's causing the issues with this case. So it's just odd to do that. But it is a cool case. I have seen these cases before, and they're often misconstrued with a T3L3 myelopathy in dogs because they don't show the same signs as cats with aortic thromboembolism or ATE or saddle thrombus. So it is a cool case from that standpoint as well, to keep people open-minded with performing a full physical examination, because the weak femoral pulses here was a giveaway that there was something wrong with this dog. Now, what's also odd about this case is that if you found weak femoral pulses, you would have started with the ultrasound typically, because that's an easier test to perform and doesn't require anesthesia for a patient that might have vascular disease. So why they did the MRI first, not really sure. My suspicion is that nobody picked up on the femoral pulses until after the fact, when they did the MRI and said, oh, there's a clot in the aorta. And then after the MRI, they probably found weak femoral pulses and they sort of made the paper fit that perspective. That's my guess. I don't know if that's true or not, but it seems odd to go with an MRI first when you could have diagnosed this condition from a abdominal ultrasound. So I have a lot of criticism as usual, but that's why we look at papers critically. Okay, thanks everybody for watching, and we'll see you again tomorrow. Bye-bye.